So talk about all the different bites that I'd like to test on. I'm going to get the snakes at the end because I think we do a lot of snakes. I think most of you understand that. But if you have to leave before at 3 o'clock, that's the part you'll probably miss. So the two spiders in the United States that they like to make test questions are the black widow, the Lactrodectus mactans, and the brown recluse, the Loxosceles species. They look very different. The thing that's most notable about the Black Widow is this hourglass orange on its underside, and what they do is also completely different. So we'll go through each of them a little separately. So the Black Widow occurs everywhere. They're here in Oregon. I see them every spring, usually about this time. Every fall, I see them as the weather gets colder. There's this hourglass on their abdomen. So of note, only the female has the venom, but they're the bigger of the two spiders, and they typically almost always live outdoors. These are not the spiders you're going to find unless there's some sort of porous hole in your environment where they're getting indoors. This is the size of them compared to a penny. This is a real close-up shot of the hourglass. It's pretty distinct. Most people can tell that it had a red mark on it. There are no deaths associated with these, at least in the year, and some major outcomes because they can be quite painful. So the bite hurts, and then it spreads radially out from the bite, and you can get local diaphoresis and then global diaphoresis, and you get hypertensive. And people have leg bites or sometimes having GI pain and abdominal symptoms. And in the old days, pre-CT scanners, people who got bit in houses on their bottoms were mistaken to have appendicitis because of abdominal pain and taken to the OR. People who were bit on their arms or in their armpits because it was in their clothes were misdiagnosed as having a cardiac problem because they had chest pain. Basically, this is just a painful bite, and we treat it with pain control. It's not aggressive. It's not going to track you down. You can have localized muscle pain. So maybe in the severe cases, the ones can get a little bit of benzos on top of their narcotic. They can be both tachycardic and bradycardic, although pain usually induces the tachycardic and hypertensive events. And it's self-limited. After a day or so, it gets better. Here's the clinical presentation treatment of Black Widow spider of 163 cases. You can see the kind of symptoms that many of them had. This is just extracted from NPDS data. Back pain or abdominal pain was predominant, followed by things like extremity pain and diaphoresis. The toxin is called alpha lathrotoxin, so Lathrodectus produces a lathrotoxin. It's a calcium-mediated presynaptic neurotransmitter releaser, so it increases adrenergic and cholinergic transmission, so you can get muscle contractions. At one point, we thought that IV calcium maybe because it's calcium-mediated may be useful, but honestly, it does not really work. Now, there is an antivenom, and we don't use it very often because in the original testing for it, there was one death that happened, and that scared everybody. But it was in somebody who they were not prepared to treat for that anaphylactic reaction, and because of that, it was sort of a one thing led to another. They couldn't get the airway, and the person died. We don't give calcium, but if you get the antivenom, almost everybody gets complete relief with a single vial. So if they're having intractable pain, you've burned through a few narcotics and maybe some benzos, I think it's fair with discussion with a medical backup to talk about the antivenom. My threshold, I think, is lower. I'm happy to use it, make sure people aren't allergic, maybe make sure they have Benadryl and epinephrine nearby. Give it slowly. They don't want to bolus anything fast. That's a foreign body, but it usually helps. Second spider we have out there is the brown recluse spider or the violin back spider. So here's a real close-up. It looks like there's a musical instrument on the top of its head rather than on its underbelly. This causes necrotic spider bites or necrotic arachnitism. Also, it calls the Loxosceles reclusa and the Loxosceles deserta. And I'm going to talk about the hobo spider in a second because it's misclassified with these. And I don't know which way a test question may come down, but I'll tell you the truth, and then you can figure out how you want to answer it on the test. So this is the range of the recluse spiders. They don't come up to Oregon and Washington. The different subspecies are mostly in the Southwest and then through the middle of the country. We have maybe 2,000 bites per year reported to poison centers. Most of them are pretty minor bites, and you get a little erythema, and occasionally you get an ulcer in the middle of it, but mostly they get better. If you haven't seen any ulceration by day 4, you're done. You don't have to worry about a risk of skin loss or anything else. A few bites, especially in young children or older people or immunocompromised people, may get a systematic response with nausea, vomiting, fever, muscle aches and pains, and joint pain, and an even smaller percent of them can develop a hemolytic anemia. This deep spreading ulceration, sort of the red, white, and blue lesion that spreads to central ulceration, can occur in a small percentage of them. This is like a worst case scenario photo where you had initially a central necrosis. It kind of went outward. It had this eschar that formed and then right around this sort of inflamed area. Most of these need good aggressive wound care, maybe by a surgeon, sometimes antibiotics, although they tend not to be infected. In worst case scenarios, they need skin grafting. The toxin is sphingomyelinase D. It degrades red blood cell membranes, sphingomyelin, therefore the sphingomyelinase to break it down. It also causes platelet aggregation, complement activation, so there could be a large inflammatory response, and intravascular hemolysis, so they may have a relative hemolytic anemia going with it. They also have tissue inflammation and destruction, and transient leukopenia and thrombocytopenia can all occur. So in really bad bites, they can have all sorts of hematologic changes, low platelets, low white counts, and low anemia from a hemolysis. There's lots of things been tried, but let me just say none of these work. Don't do them. Dapsone, hyperbaric oxygen, colchicine, nitroglycerin, steroids, electric shock. People have done, it's crazy things. It's basically good old basic wound care. Take care of it, clean the edges. If you really feel you must give antibiotics, fine. But that's all that's necessary. Occasionally, they do need grafting. Here's a clinical outcome of 111 bites. 8 were admitted, 3 required skin grafting, so 3%. Here's another cases, all healed on their own. So let's get back. Where did this hobo spider come along? It all dates back to a 1996 MMWR report, with the lead article being necrotic arachnism in the Pacific Northwest from the 80s through the 90s. And they identified this spider, the Tanginaria agrestis, which got miscommunicated as the aggressive hobo spider or the aggressive house spider. Its range is in the Pacific Northwest in Idaho, but it really isn't that bad of a spider. It got imported from Europe, never caused disease or problems in Europe, but for some reason here with that report, people felt that it caused all sorts of necrotic arachnism. They live in basements. They are not a house spider, and they usually have a small painless bite. Some people get a little headachy and myalgias, but it's usually pretty transient. Some of them form blisters, but very few. And you can get a central lesion that occurs, but a few of these cases have been truly identified. There's been case reports where they've showed big lesions that are scabs. However, they don't really get these big, deep wounds like the brown recluse spider does. This is what a typical one looks like, and this is about as bad as a typical one ever gets. So there's a famous woman over here at Lewis and Clark College named Greta Binford. None of this is going to be on the test, but she tried really hard to get these hobo spiders to bite animals and students. And she put the spiders into rabbits and tried opening their jaws, and no one got bitten, and saran wrapped the spiders down, and no one got bitten, and tried to give electric shock to them, and then it didn't really work and our funding ran out. But these are not aggressive spiders. They will not chase you down. Their jaws do not penetrate normal skin. They potentially can penetrate the skin of a young child or an elderly person, but they don't cause anything more than that small puncture wound that we saw. There's some other spiders in Australia that are kind of mean. The funnel web spider. It's the most lethal spider. Often, that's the literature says. It's got neuromuscular blockade within minutes, so it's almost like, you know, blue-ringed octopus bite. You get paresthesias around the mouth and diplopia from paralyzing cranial nerves. And there's been 26 deaths in Australia prior to the development of an antivenom, which they now have a rabbit-derived IgG full molecule antivenom. When they give it to folks, they basically, when they start having symptoms, it works pretty good. So, scorpions. There are 30 U.S. species of scorpion, and only one is pretty dangerous. Um, there's 11 deaths per year over 4 years. So that probably makes it close to like 3 deaths per year. They're pretty rare. More deaths in Mexico for different reasons, perhaps, have to do access to care, the more so than the toxicity of the spider. And it's mostly young children who get into these or get stung multiple times that have problems. The ones we worry about in the United States, the one that's testable and you're going to see, and we might actually have to do something about, is the Centroides spider, the bark scorpion. It's known to hide in shoes and blankets and sleeping bags when you're camping out in the summertime. And they're kind of small and they don't bite, they sting. So this little arched thing at the end of their tail, this telon, can actually swing around and sting you. It's not their mouth that's biting you. This is what it looks like up close. It's about a couple of millimeters long. It's pretty pointed. And generally, they're not too aggressive unless they happen to be stuck in your shoe and they have a big foot coming down on top of you when you didn't check your shoes. And then they'll swing that talon around and stick it in your toes. The potency varies from something that feels like the flu to death in some rare cases. But it's a sodium channel opener. It causes repeated firing. It's a lot more serious than the plants we talked about yesterday that are also sodium channel openers. You get excessive catecholamine release, cytokine release, and some of them even have cardiac and nephrotoxins in it. Pancreatitis, often a roundsmanship question, but that only happens with the Trinidadian scorpion, not the bark scorpion. Here's the range of the bark scorpion. It's pretty much southwest California, and it's not even up in Northern California. It's really the southern part of the state. This is the Trinidadian scorpion, the Titius scorpion. This is the one that causes pancreatitis. It's gigantic. There's very few bites that I've ever heard of in the United States associated with this. There was some paper once written that says it causes pancreatitis, mostly based on elevated amylase levels. Even it was in the pre-lipase days, although clinical features of pancreatitis were not particularly associated with the elevated amylase. So who knows what that was really related to. But people love asking what causes pancreatitis. And, if you want to show off, you'll say scorpion bites do. But again, scorpions don't bite you, and it's not the usual scorpion sting that does this. So this is a mixture of autonomic effects from both sympathomimetic and parasympathetic overdrive, usually associated in the severe cases with cranial nerve findings. So you kind of get this sympathomimetic hypertension, agitation, hyperthermia, tachycardia, along with symptoms of parasympathetic, like organophosphate, salivation, lacrimation, urination, defecation, vomiting sort of picture, then with weird cranial nerve roving and rotary eye movements, ocular clonus, blurred vision, fasciculations of the tongue, and difficulty swallowing. So this is sort of a graph from a recent New England Journal article showing you the 3 areas where they can have effects on the heart, causing arrhythmias, causing myocardial depression, causing shock, causing pulmonary backing up and causing pulmonary edema. So some of these can be quite severe if they get you with a lot of venom. The kind of good news behind this is we can grade the degree of envenomation, and based on that, we can offer an antivenom, which exists in the United States. So the vast majority of stings, I keep saying bites, but stings are grade 1, where they have local pain near the sting site, maybe with some numbness around it, and that's all. Grade 2 is there's pain and paresthesia moving away, like up the arm or the leg from the bite, and that is another 9%. So this is over 90% of all things are these grade 1 and 2, and neither of these require antivenom. These are mostly pain control and wound care events. Grade 3 is where you start having either cranial nerve findings, like the ocular findings, or somatic neuromuscular dysfunction, perhaps as little as 5% additional ones. And the grade 4 is where you have both cranial nerve findings as well as local pain, as well as somatic neuromuscular twitching and dysfunction, very small percentage. Grade 3 and 4, especially in children, should be treated with the antivenom, which is anascorp. Local therapy helps, but IV midazolam has been tried in a couple of case reports. Most patients who have grade 3, they get relief with the effusion. It's hard to do this. You have to sedate them, keep them in the hospital for 24 hours. But the vast majority of people who are treated with grade 3 or 4 um, antivenom, the anascorp, get better within an hour or less sometimes. And honestly, they say, I'm ready to go home. I don't need to be admitted. And that's probably not unreasonable unless there's some signs of allergic phenomenon happening. They can probably be watched for an additional 60 minutes or so after the infusion ends. And at that point, if they're having more symptoms, they get another dose, and those will get admitted, or they can go home. The dose is the same for adults and children. It's 3 vials of antivenom. So lastly, in the last few minutes, I know we know about snakes a lot because we've treated enough. There are the Cortalidae snakes, which are the rattlesnakes, the cottonmouth and the copperhead back east, and the Elapidae, or the coral snakes, which are mostly in Florida for the most part. Here's the eastern and western diamondback, these variegated back snakes that propose most of the bites. This is a copperhead or an echistrodon snake. You can see its range is mostly in the southwest, and the cottonmouth doesn't have the variegated back or the copper color, but has sort of a white line around its mouth. This is the one Echistrodon species we see in Florida and along the Gulf Coast. We had original Wyeth antivenom, but now for the last 20 more years, we've had Crofab. The differences between them are a couple of things. One, they use different snakes to produce the antivenom. So both use Western and Eastern Diamondback, but the Crofab uses more North American snakes, such as the cottonmouth and Echistrodon species, and the Mojave rattlesnake, one that has some neurotoxicity. The original one used South American and Caribbean snakes, which are just not a problem in the US. And the way they make this is they take the full IgG molecule, and you can do one or two things. You can slice it and just leave this little end of the Y out with the active green part here, which is the binding site, or you can do a deeper slice down here and have a 2 FAB2 fragment that has 2 binding sites, but it's a larger molecule. The FAB fragment is Crofab. The FAB2 fragment is Anavip. And those are the 2 products that are available in the United States. So Crofab is made from sheep as opposed to the original one, which is made from horses. It's also purified to a greater extent and has less contaminated foreign proteins in it other than the FAB fragment. They use these 4 snakes to make the product. They slice it with papain, and they end up with 2 FeV fragments per molecule. People allergic to papaya might be allergic to Crofab. Loading dose is 4 to 6 vials. Repeat as necessary to control the initial swelling, and then maintenance dose is 2 vials every 6 hours for at least 3 more doses. Can go longer than that. There's a small risk of anaphylaxis, but unlikely to have true serum sickness, which is a rash, fever, and even urinologic problems with proteinuria. Mostly that was a problem, serum sickness, with the original Wyeth antivenom. Anavip, the newer product, is made from horses, not sheep. It takes the FAB fragment and cuts it lower with pepsin so people can get it if they're allergic to papayas. It's been approved for the last almost handful of years. It uses both the 2 snakes, the Western and Eastern Diamondback, but also the South American snakes that were used in the original Wyeth product, including the Fer-de-Lance. So Anavip uses pepsin, not papain, breaks into 2 fragments. Usually we just give 10 vials once, slowly. They don't need a maintenance dose. It lasts longer. It's less risk of recurrent coagulopathy, but I think all those things need to be checked for. You need to check INR, platelet count, and thrombins on these folks, anywhere from fibrinogen on these folks, 3 to 5 days after you finish the treatment. So they all need to come back for sort of a second look to see how they're doing. Coral snakes are mostly in the Delta, Mississippi Delta region. They have a neurologic symptom with bulbar paralysis of the cranial nerves, ptosis, diplopia, dysphagia, trouble speaking, fasciculations of the tongue, can progress to diaphragmatic paralysis and therefore needing intubation and respiratory failure. There are 3 subspecies, but neither the Arizona nor the Texas species are all that toxic and rarely ever need ICU level care. The eastern coral snake from Florida is the one that's really the biggest problem. They can have pharyngeal spasm, salivation, and need to be intubated if not treated with the antivenom. So if you don't have antivenom, and for a few years we ran out of antivenom and we couldn't treat them except for supportive care, a lot of those people ended up in the ICU for long periods of time, sometimes as long as a month or longer, with respiratory insufficiency and progressive descending paralysis, and they required intubation for ventilator support until they got better. There is and was FDA approved antivenom that has constantly been in short supply. It prevents the progression but does not reverse effects. So if you come in with subtle neurologic symptoms, weakness, or diplopia or cranial nerve findings, similar to what you would use the threshold for a scorpion bite to treat, you should probably get the antivenom if it's available. And even expired antivenom is acceptable because they've stopped making the North American antivenom in this country. So in summary, there are 4 antivenoms you should be aware of. Crofab and Antivip are used for rattlesnakes. The coral snake antivenom is used for coral snakes. Antiscorp is used for scorpions, and their black widow antivenom is helpful in rare cases that have intractable pain in black widow bites. There are other antivenoms around the world that are not available in the US for other venomous creatures such as stonefish and box jellyfish and funnel web spider we mentioned. All those are available only in Australia, and we can't export them even to a place like Guam, where we sometimes have box jellyfish and stonefish envenomations. Despite that and their proximity, we can't get those venoms to a place like that. They're limited to just the Commonwealth of Australia. I will stop there. We ran over by a few minutes, so hopefully haven't detained anybody too long. So questions and notes. So they now changed the genus species of the scorpion to Centroides sculpturatus from the Excel, whatever the other one is. So be aware of that on the test questions. Paresthesias can move anywhere around the body. Yeah, I'm not sure it'd be a question, but yeah, it could happen. People get anxious and sort of have a lot of somatization after bites of all sides, scorpions and snakes and whatnot. So you have to kind of pick apart what's real and what's not real. So any other questions, thoughts about anything at all? It's on the test. As far as I know, they can't ask all of the above or none of the above questions. They have to ask a one true answer question. They can't use double negatives, which of the following is not true kind of thing. And usually they like doing like little scenarios, like someone comes in, this is what happens to them. And they either they'll say, what is it? Or what would you do next? Kind of making you a kind of a 2-part question where you're thinking ahead. They expect people to know what it is, perhaps, but not know what to do or what labs might be abnormal. So those are all the kind of questions you might want to be prepared for. I'd say in general, everybody who's been practicing, especially in our shop where we have lots of protocols, which are all good to study because they are the basis of what is out there as far as standard of care, will get you through this test. But all these lectures are now posted online, I think, and took care of that yesterday. Yeah, they're not supposed to do double negative questions, at least when I was writing questions about a dozen years ago. Um, those are kind of frowned on. All right. Well, everybody, good luck, first of all, and have a good afternoon. So the sun's coming back out, so I'm sure you've had enough of talks for today. It's probably worth getting outside and taking a walk somewhere.
Thank you, Zane.
All right. We'll see you all around the Poison Center in the next few days or so.